We're rallying the NANN community to help grow NANN by 500 new members in 2026. Your referrals make the difference, so invite a colleague, share in your unit, and help us grow the profession's collective voice. When you refer new members, you'll also earn badges in My NANN and unlock exciting new referral rewards. So spread the word and help us grow. Hello and welcome to NANNcast. I'm Jill, your host. When we talk about developmental care in the NICU, are we really all talking about the same thing? Some nurses think of positioning, others think of sleep protection, and others think of family involvement. But what does developmental care really mean? Today, we're breaking down what neonatal developmental care truly means, how it impacts short and long-term outcomes, and why it's more than positioning or clustering cares. It's a holistic, cue-based, family-centered model that shapes the infant's brain and emotional development from day one. I'm joined by Dr. William Hull, a neonatal nurse practitioner and chair of NANN's Developmental Care Specialist Task Force. He is a leader in neonatal developmental care, educator, and longtime advocate for neonatal developmental care and family-centered practices in the NICU. Together, we'll unpack what developmental care actually means, why it matters, how to implement it, and talk about NANN's newly updated Neonatal Developmental Care Specialist designation. Let's get right into it. Thank you, Will, for joining us today. I feel like when we talk about developmental care, it's such a loaded question. So if I was to ask you, what is developmental care? There's probably a million different answers. But how do you answer this, knowing that there's so many varying interpretations to this term?
Yeah, absolutely. So I 1000% agree. Depending on what you're looking at and where you're reading and what you're looking into, there's so many different nuances and intricacies to neonatal developmental care. And then not only that, but neonatal developmental care can branch out into family-centered neonatal developmental care, and then it can branch out even further. So really, the way I look at neonatal developmental care is that it's really individualized, cue-based care. Narrow it all down, everything down to the infant, right? Make sure that what we're doing is for the infant. Make sure that we are not doing things just because we have to do them, just because to check a box. We're making sure that what is being done is needed. And if we have to, kind of wake the kid up, or if we have to do something that is outside of the cluster of care, then there needs to be a purpose for it, not just because this is what we do, right? I've worked at several facilities where they say, well, lab draws are at 5 a.m. Or at 3 a.m. or whatever, right? Whatever time they chose, but the infant's cares is 6. And you're like, well, it's not quite time yet. Can we push it back? And unfortunately, a lot of facilities and a lot of other places think that when you're looking at neonate, when you're, trying to do a task, you have that task. You're very task oriented. But when patient care, we need to kind of branch outside of being task oriented and kind of be, again, individualized in our care and in our tasks.
Thanks for simplifying that. I think nurses for their small baby programs are very focused on cue-based care, but we tend to forget some of the other babies that we're caring for, our term babies. Some babies that have been there are small baby graduates, so to speak. So we need to continue that, developmental care process, that cue-based care. Can you go into a little bit more detail about how this looks in practice for babies other than just our small babies?
Yeah, that's a great point to make and a great distinction to make as well. Even though there's a lot of hot button topics on small baby care, and you see it all over the literature about, well, small baby care starts before delivery, right? Even. And I think that's important to make that distinction and remember that, yes, they're small babies, but they grow to be big babies. Right. And I think that when we're looking at these small babies and how they're growing, we have to continue that developmental thought process all the way through the NICU and even outside the NICU. It's something that we have to teach parents to do when they go home. It's something, as a former NICU parent, that's something I had to learn, making that transition from having a very small baby at 22 and 1 weeks all the way to going home and even doing therapy at home and making those type of changes so that we are still allowing our infant to develop neurologically, developmentally. So making sure that our infants continue to thrive in these environments. When we're looking at our small babies that are now term, or even our infants that are admitted as late preterm or term infants, you still have to have that developmental thought process in mind because they're still growing. And I think that's an important distinction, an important thing to remember is that these infants, even if they're term, even if they're post-term, even if they are a big fat LGA kid, they're still growing. And we have to be extremely mindful of that.
Yeah, and I think we know those terms, right, as bedside nurses, protected sleep, clustered care. But sometimes I don't think we always connect that to the neurodevelopmental outcomes of those babies. Like you said, these small babies then grow up to be big babies, and we have to teach these parents the importance of that for when they go home.
Right, exactly right. And I think too, as the baby gets bigger, their developmental care becomes even more nuanced and even more intricate because think about a kid who was a former 25-weeker and is now, let's say, 36 weeks and is learning to nipple feed and mom wants to breastfeed only. Well, but we tell mom, oh, you can only breastfeed every 3 hours, but she's there all day. Well, why can't we do skin to skin in between those 3 hours? Why can't we let mom nuzzle? Why can we not let mom nuzzle with the baby while you're getting labs drawn? I mean, I personally have never drawn labs with a neonate and they're doing skin to skin, but that is best practice. That is what we should be doing for that pain management, for that non-pharmacological pain management to be offered to the infants. And then, of course, creating that healing environment as well and that caregiving culture so that parents are not a bystander. Instead, they are part of the infant's care.
You mentioned family-centered care, and I think, like you said previously, sometimes people think that family-centered care and developmental care are two separate things in their NICU. But I think that family-centered care can look different from unit to unit. Can you tell us what does true family-centered developmental care look like to you? And how can we implement that in our unit?
Yeah, absolutely. So when looking at family-centered care, for me, what that means is that the parents are actual caregivers. They're not visitors. And unfortunately, in our NICU culture and our NICU population, and I can only speak from my experience, I can't speak across the nation or across the world or globally, but from what I've seen is that we often view parents as visitors, as they're only here for a short period of time and then they leave. Or we have, quote unquote, visiting hours. You can only be here from 5 to 5 or whatever, right? You have to leave for change of shift for HIPAA reasons or whatever. But really, family-centered care means that we should have those parents be there constantly, consistently. It is their baby. And one of the big things that I have learned and have grown to appreciate is, especially as a former NICU parent, moving into academia, moving into being an author, is that we need to encourage family presence in every aspect, whether it's a diaper change, whether it's a temperature check, whether it's a feeding, that this is their baby and it is not a task to just check the box and move on. While sometimes we like to, in healthcare, we like to get in that mindset of checking boxes and tasks and moving on to the next thing, right? You have 4 8 o'clock babies that all need to feed at the same time. Get it done, right? But we have to realize that when the parents are there, well, they can do all that, right? We have to teach and educate and offer that advocacy for them to say, hey, I have other babies I need to feed. Do you want to do all this? Have you been taught how to change a diaper? Do you know how to take a temperature? Do you know how to feed your baby, right? And unfortunately, sometimes there's not that consistency where every professional in each shift is teaching parents. And unfortunately, too, it's also life, right? Not every parent can be there. My wife and I were very blessed to be at our son's bedside constantly. From change of shift in the morning to after change of shift at night. We were there every day. We were very blessed. And unfortunately, that's not the reality of a lot of parents. And so I think grace comes into that as well, offering parents grace and saying that you can't be here 24/7, but when you're here, tell us what you want to know. And unfortunately, a lot of parents don't even know what they want to know because they saw their little 24-weeker and afraid to touch the kid because its skin is gelatinous. And then now they see this big kid and they're only thinking about the 24-weeker. They're not thinking about this big kid anymore. And they're still scared to touch the baby because of how fragile he was. And even though now he's big and crying and active, well, he's still fragile to them. And I think we still have to remember that. And so sorry, that was a long, drawn out answer to family-centered care and my viewpoint of family-centered care. But essentially, it goes back to how we were defining what developmental care is. It's drawn out. It's not cut in stone. It's not, ABC. It's an art and it's messy. And I think a lot of people are uncomfortable with developmental care because of it being messy. And we are afraid, not we, but generally, we're afraid of getting messy. We like our routines. We like A, B, C, 1, 2, 3. And that's not developmental care. That's not family-centered care.
Yeah, I think you hit the nail right on the head. Nurses are very type A, especially NICU nurses and the tasks. But I love how you said to give parents grace and include them, ask them, what do you want your day to look like? Because maybe they're terrified to give their once 24-weeker a bath. But if you can have them join you and to learn and, it's not scary, like we're going to get through this together. But I also think that nurses can be very intimidated with asking parents to do stuff because maybe there isn't trust, like with a very acutely ill baby, right? So you have a micropreemie or you have a post-op baby that, is on a lot of infusions and paralyzed or what have you. How would you guide a nurse to improve that partnership with families for those high acuity babies that they're caring for?
Yeah, absolutely. And I just want to make a quick distinctive point is I am not saying nursing care is bad or anything like that. I'm not saying any of that, right? We need to make that distinction. The nursing care that is given to these infants is amazing. And these infants are thriving and growing because of the nursing care they receive, this specialized neonatal nursing care from all aspects. And not just nursing either, therapy, provider care, the whole multidisciplinary team coming together to help this infant grow and develop. So to go back to your question of how can we, as a team, include parents, especially when they're acutely ill, one of the biggest things that my wife and I did when our kiddo was fresh is one of the nurses was I don't want to say her name because but she was integral to us providing family-centered developmental care. Even though we couldn't really interact with our neonate, right, our son, she gave us opportunities. Well, would you like to do oral care with your breast milk? Here's a cotton swab. Let me show you. I'm going to show you first, and then you're going to do it. I'm going to put my hand over your hand, and we're going to do this together. When you're doing oral care, the way I explain to parents is it's like brushing your teeth, but a little bit gentler, right? Another example is, okay, have you read to your baby? Are you reading to your baby? Are you talking to your baby? Especially with moms, right? Because the babies listen to the moms talk, laugh, do all the things in life, right? And then the babies are taken out of the intrauterine space, and now they're out in this big, wide open environment that's chaotic. And then by listening to moms talk, they're able to regulate themselves. Same thing with dads. Dads is the same, right? Because mom and dad have conversations constantly while baby's in utero. So by offering that verbal stimulation, it's good. We want that, right? And it kind of takes away from that chaos that's happening in the unit. Another thing that we could do is offer, some people may be, especially if it's an extremely low birth weight infant, some people may be a little hesitant on allowing the parents to change the diaper just because of all that auto-regulation that's not fully developed and the increase for IVH and sudden decompensation. But there's other things that we can do. That we can touch the baby's hand, right? We can show parents how to safely love on their infant and safely provide that connection, right? It is scary. And I think that's a big thing to recognize is that not only is it scary for nurses, it's scary for the parents too. And I just think that it's extremely important that we see that and we understand that.
Yeah, and I think that's also very empowering to parents, and they feel like they have a say and that they can bond with their child. They're creating this healing environment just by talking. Maybe they can't be as hands-on as they want to be, but like you said, just talk to your baby, touch their hand. There's so much negativity around being in a NICU for a baby, the loud noises, some of the negative touch where we have to do labs or what have you, but to have that positive interaction with a parent or caregiver can really create such a healing environment for them and also promote amazing neurodevelopmental outcomes. And that's what you need to make sure the parents are aware that this is shaping their future, these small interactions that you're doing every day.
Yeah, absolutely. The small and mighty interactions and I think that's important too, is that we don't minimize any interaction or intervention that's going on between parents and their infants, between parent and the medical team or the healthcare team. We need to not minimize that. Instead, we need to stress that all these interactions are extremely important and that they are setting the family up for life, essentially.
So let's talk about impact, because as we know, developmental care isn't just something that's nice to have or if you have extra time to do it, but we know that it's a core part of being in the NICU and it's essential. When developmental care is prioritized consistently, what benefits do we see for infants?
Yeah, I think that's a great point you made in that question. And I would like to just hone in on that a little bit. Sometimes we think of developmental care as kind of like a soft science, and it's not as, robust or as exciting as a baby with drips or as going to a delivery or whatever, right? But it is a hard science because eventually what we're doing for these infants is we're reducing their stress. We're reducing their pain. We're supporting brain growth and sensory development. We're improving their sleep. We're improving their overall growth and physiologic regulation. We are, again, setting these kids up for a life, for their future. We're creating these bonds for mom and dad to be with the infant or parents to be with the infant. We're essentially assisting these families to create a life together.
So we talked a little bit about the impact. Can you share some examples of physiologic or long-term developmental outcomes that improve when this care is done well?
So that's a great question. So there's a lot of outcomes, both short and long term, that we see positive outcomes that we see when we're implementing consistent developmental care. And I think that's the key word, is the consistent part. It has to be consistent across units, across shifts, between nurses, between providers. It needs to be consistent. Like I said, there's so many short and long-term neonatal positive outcomes, but there's also an improvement in family-centered outcomes or family unit outcomes. This is an avenue to provide holistic-based care to make sure that we are providing that well-rounded care to these neonates. One of the things that we see is an improved in self-regulation when you're providing consistent developmental care, such as if it's a loud, chaotic environment, we can see that the infants aren't having as many apnea-bradycardia events. They're able to lower their FiO2 needs. They're tolerating feeds, which means that they increase weight, right? They increase weight at or have an improved weight gain in a shorter amount of time, which helps decrease the length of stay, which helps decrease the healthcare costs that we see. Unfortunately, having a NICU baby is extremely expensive, especially if you have an extremely low birth weight infant. For example, my kiddo they call him $1 million baby because he was born at 22 and 1, and his whole NICU stay. And even if you just look at the NICU space alone, just the bed space alone is so expensive. So you see all of those short-term outcomes. As far as long-term outcomes, you have improved learning capabilities with the infants. You have an improved family system. Your family system, when you incorporate all members of the family into the neonate's care, the likelihood that the family unit will stay together increases. With the family unit staying together, there's also an increased bonding. There's increased bonding for a mother to infant or father to infant or parents to infant. There was some literature that came out that talked about how having an infant in a NICU stay obviously is not only very stressful to mom and dad, but it's stressful to the entire family unit. It can lead to a fractioned family unit, which means that the family splits off and is not together anymore. And compound that with a medically fragile infant or an infant who it needs specialized care outside the NICU, that risk dramatically increases. So by offering this consistent developmental care, we're significantly improving the long-term outcomes of these infants and of the family.
And I think every nurse can see that themselves when they're caring for a baby. You come in, you see your preemie all splayed out in bed, and then you snuggle them in the Snuggie Up, and you can see their vital signs instantly improve. They go back to baseline. You see it in all of the literature on kangaroo care. So the literature is there. The research, the data is there. It's just we need to make a change in culture on our unit to incorporate that consistently. I like the way you said it has to be with everybody, the nurse, the provider, the therapist, anybody that comes into contact with that baby has to consistently be providing developmental care for these babies and make it a priority.
Exactly. Make it a priority. And I think that's an important distinction to make, that this is not extra work. This is not something to add on to your task. Remember, we are dealing with lives and we're dealing with infants. We're dealing with these little itty bitty tiny humans that are so fragile that anything we do can send them a certain way. So I think that's important to remember that. And talking about kangaroo care, I actually did a quality improvement project on kangaroo care in one of the facilities that I'm at. And one of the biggest barriers we found is that nurses, it was specifically nursing focused, but that nurses were very hesitant because they didn't know how to offer it. They didn't know how to bring it up. They didn't know how to talk about it. They were nervous to say, well, I don't know, let me get help. Let me find somebody to help me. And I think as a culture, especially NICU nurses, especially us being type A, even though I'm a nurse practitioner, I'm still a nurse, right? And I'm still a NICU nurse. And so I take full ownership of that type A personality and wanting to do, what's right by myself without help. But we need to be comfortable asking for help, right? Because again, it goes back to the patient and the family. What do they need? How can we help them do what they need to do?
And I think this shifts nicely into the how, because knowing the principles is one thing, because we all know developmental care is extremely important. We know kangaroo care is important, but you said you found that there's a lot of hesitancy for kangaroo care. How do you implement this in a busy NICU where there's a lot of activity, a lot of babies, a lot of high acuity? What are some realistic, high impact ways nurses can incorporate developmental care into their daily practice?
Yeah, absolutely. That's a great question because unfortunately, one thing I've noticed is that, like I said prior to that, developmental care is kind of viewed as a soft science, as a soft type of, cushy thing that we do for infants, but it is not. It is a specific science. It is a hard science. And unfortunately, developmental care as a whole, the art of developmental care is not being taught. It's not being passed on. It's not something that an experienced nurse is truly making a point to teach the newer nurses, right? So I think it's important that we do pass that on, and we do pass on these intricacies. Developmental care, yes, we talked about kangaroo care. Yes, kangaroo care is beautiful. I love kangaroo care. I love oral care. I love OPI, which is the oral pharyngeal immunotherapy. My DNP project was on noise reduction, environmental noise reduction. So, but that's not only developmental care. Those are just certain aspects of the NICU environment. So one thing we need to talk about is increase education for it, increase learning for it, increase offering learning and education for that. A lot of developmental care is hands-on. Positioning the baby is developmental care. Providing good sensory input is developmental care. Sometimes what you see in the units, especially if they're private or if they're private roomed units, is that we typically see the doors closed. It's completely quiet. It's completely devoid of noise. That's not developmental care. We see if there's noise in there, it could be a song machine or a sound machine, and it's full blast. That's not developmental care. We need to be conscientious of this. But then at the same time, we also need to say, if we see something, I don't want to say wrong, but if we see something that isn't developmentally focused, we need to be able to speak up and advocate and say, hey, I saw in room whatever, that the speaker was on to 100%. The baby doesn't need that. The baby still needs time to rest, right? When we're doing positioning in a Z-Flow, for example, and this is not a plug for Z-Flow, but when we're doing a positioning in a positioner, we need to make sure that our babies are positioned midline. We need to make sure that we have hands to mouth. We need to make sure that the feet and the knees are tucked in. We need to make sure that their bodies are supported, because that's also developmental care. And that is such an art to learn, of how to position a baby a certain way so that they are comfortable. And that's an art that we need to pass on. Some people will say, well, if we put the hands to mouths, then they're going to pull out their OG tube. They're going to pull out their NG tube. They're going to pull out their ET tube. They're going to pull out their IV, whatever it is, right? Okay, well, let's figure it out. Let's work together to find a solution so that this baby stays safe, right? Because safety is always priority. Safe care is beyond the top of the pyramid. But at the same time, we can provide safe care while providing developmentally conscientious care. So if you're putting a baby's hands by their mouth, okay, put it by their mouth, but make sure that their ET tube is blocked, right? Like that they can't grasp their fingers on it. They love it because that is a reflex that they do, the grasping reflex. That's just part of it. That's what they're going to do. Totally fine. If they pull out their feeding tube, okay, they pull out their feeding tube. Let's just put it back in, right? But of course, when we think that way, we think also that, well, that's more work for me to do. If they pull out their feeding tube, then I'm going to have to take 5 minutes out of whatever I'm doing to put the feeding tube back in, right? But that's what care is. That's what we're providing. Another thing to be mindful of is don't put gloves on our baby's hands. We don't want to put gloves on our baby's hands because they should be able to feel their environment. They should be able to feel their skin, feel the soft cloths. By putting gloves on an infant's hands, you're taking away that ability. And that is not developmentally conscious. I think another thing, sorry, I'm going to go on a tangent. Another thing to be mindful of is that every interaction is an opportunity for teaching and for learning. Every single interaction, whether it is from provider to nurse, from nurse to therapist, therapist to nurse, therapist to provider, family, providing an interaction with family. All of these are opportunities for learning and growth. We should be willing and open to teach others. That should be a foundation for all neonatal healthcare professionals, is that we be open to teach, and not only to teach, but to take constructive criticism, right? To take tips and little nuances that we're hearing from other people. Now, the delivery may be a little different. It may be a little hard. So intrapersonally, we have to work on that on ourselves, but we should be able to share knowledge across disciplines and even to the family and from the family to us. Remember that, again, this is the family's baby. They know their baby. So we should not take what the family is saying and be like, they don't even know, right? And roll our eyes. No, we should take what the family is saying and be like, thank you for offering that suggestion. Let's work together and get this done. Let's work together and get your baby situated, even if it's a 22-week preemie, even if it's a LGA 39-weeker. Let's work together so that we can have your baby situated and that you feel comfortable, I feel comfortable, and the baby's safe.
That can't be more relevant with the fact that you said developmental care is an art and the importance of teaching one another, because developmental care is not something that you can learn on a PowerPoint. Yeah, you can see different positions that are good for babies depending on what gestation they are, but to, know how to position that baby, because we talked about it. Positioning is just not positioning. Care is just not care if you're not incorporating these developmental care practices that we talked about. And it is important. Find a nurse that you admire and how she cares for those micro preemies, and watch and see how they position the baby. Learn from them. And like you said, take that feedback and internalize that so you can, then mimic those practices in your care. So that, I think, is one of the most important takes, is that developmental care is something that you need to observe and watch, see what other nurses, providers, or therapists are doing on your unit and learn from them.
Exactly. And, it is, I don't want to minimize it either. It's intimidating. It's intimidating to ask an experienced nurse who's been there for, I don't want to say a number of years, but it's intimidating to talk to them. It's intimidating to say, hey, I see you doing this. Can you show me how to do that? Because I think as a humanistic perspective, we don't want to say, oh, I don't know how to do something. But we need to be able to say, I don't know how to do something. Will you teach me? Right? I think it's extremely important to, again, if you learn a certain style or if you learn a certain way, to share that with other people. If you're a new grad nurse who has never stepped foot in the NICU and you learned how to position a baby this way and the baby loved it, okay, well, let's share that. Let's see if we could build on that. Let's share that with your other new nurses, with your other colleagues, because I can guarantee you they wouldn't know because we're not teaching it. We don't teach it in undergrad. Mm-hmm. We don't really teach it very rarely in graduate school. And then I can pretty much guarantee you that in orientation, it's even less so taught. And like you said, sometimes there can be a PowerPoint that's on it, and that's great that there's a PowerPoint on it, but it's different. Versus, and I think we've all experienced this, it's different from reading in a PowerPoint in a book to actually implementing it. It's night and day. And it is an art, and we have to be open to that art. We have to be open to making that uncomfortable change. And unfortunately, that is developmental care, right? Is creating that uncomfortable change to make it comfortable.
Exactly. And I love when I'm caring for a baby and a family member says, they really like to be prone, or, oh, they hate that, don't do that, because those are those pieces of information that are so helpful. Yeah, some people get offended that a parent's telling them how to do their job, so to speak, but take that information. They're the ones that know their baby best. And that can really make your shift a lot easier when you find that sweet spot position for that baby.
Right. Exactly. And I think too, I think you brought up a great point about, someone's telling us how to do our job. And I don't think we should look at it like that. Again, I don't think we should look at, well, they're trying to dictate what I'm doing. No, they're not. Remember, go back to the basics. Take it back, all the way back. This is their baby. They've lost all control over their baby. A lot of parents, and you can find this all over the literature and a lot in studies, that a lot of parents voice that they lost total control of their infant. They weren't there for the first bath. They weren't there for the first diaper change. They weren't there for the first time the baby got swaddled. And those are things that, I don't want to say we take for granted, but it is a big thing for parents. And so we need to bring the humanistic side back to the NICU.
Feeling inspired? Developmental care is the foundation of neonatal practice. Now, the updated Neonatal Developmental Care Specialist designation gives you a clear way to validate that expertise and strengthen your credentials. The exam is self-paced and online, so you can complete it on your own schedule. Once you pass with a score of 80 or higher, you'll earn recognition that lasts for 3 years, with renewal options that fit your professional development plan. Start your designation today at ilearn.nann.org/designations. Now that we all understand the importance of developmental care, what resources would you recommend for nurses, providers, therapists, whoever works in the NICU environment to use to help incorporate developmental care in their practice?
So that's a great question. There's not a lot of abrupt information in your face, but there is a lot of literature and information out there. Just to make a NANN plug, there's the 3rd edition of Developmental Care for the Newborns and Infants. You can always find developmental care articles on advances in neonatal care or in any other journal. Anytime you're a member of an organization, sometimes they'll have a journal that's attached to it, so you can definitely look through there. Another thing that may be interesting for new grad nurses or our newer generation of nurses is AI. Using AI to find information or asking AI, how can I implement developmental care in the NICU? Some prompts that you can use is, how can I implement developmental care in my unit where developmental care isn't frequently practiced? Type that in ChatGPT and it'll bring you up a wealth of information or whatever AI modality you want to use. Another one is, what are some ways I can implement developmental care in my everyday nursing care? So that is even more specific because that is directly to you. And then you can add in your infant's gestation. Of course, HIPAA compliant. Don't ever add birthday or names or anything like that. But you could at least add their gestation. 36-weeker, 34-weeker, how can I implement developmental care in my everyday practice, right? Another one is how we kind of talked about with the culture and needing to change culture. And unfortunately, culture change, there's so many studies and so much literature on changing culture in a unit. And that is by far one of the hardest things to do. I think anyone can attest to that, is ways to change culture. But a question you can ask AI is, how can I encourage my coworkers to implement developmental care without adding extra tasks to their daily work? Remember, we talked about that a little while ago about how a lot of people think developmental care is adding tasks. You already have your set task. You have, like I said, 4 8 o'clocks, got to get them done. But with those 4 8 o'clocks, how can I improve their developmental care? What is an option that I can do? Again, it can go back to something as simple as putting hands to the face, facilitated tucking, positioning, offering non-nutritive sucking while they're getting gavage feeds. And these are just questions that you can ask AI. And of course, there's a million other questions you can ask. Even asking AI, what questions can I ask AI about developmental care and how to implement it, is just another option.
Thank you for those resources and those AI prompts. I think they will be very helpful for anyone that is looking to deepen their understanding of developmental care and improve their practice. And this is also perfect timing to mention NANN's Neonatal Developmental Care Specialist designation. Can you tell us more about that?
Yeah, absolutely. As the task force chair for revamping the Neonatal Developmental Care Specialist designation through NANN, it is different than a certification, but with the designation, it does signify expert knowledge in providing developmental care specific for neonatal developmental care. With the designation, it is a 100-item test. We revamped the test and the exam so that way we could tie it in with the recommended text through NANN. And that recommended text was the 3rd edition of Developmental Care of Newborns and Infants. With that, in order to pass the exam, you do have to get an 80% or higher. The exam consists of scenarios and knowledge-based questions. So there's 2 parts to this exam, and it's good for 3 years. You can put it on your signature. You can say you're a developmental care specialist, all those things.
Who do you think would benefit most from earning it? bedside nurses, APRNs, therapists?
Great question. So it is for anyone who provides neonatal developmental care. The qualifications, you do not have to have a certain number of years. It is an exam that you just take. It can be for physicians, it can be therapists, it can be nurses, new grads, it could be even nursing students or wanting to move into the neonatal world. Again, it sets you apart from colleagues. It sets you apart from those who are also applying for the same job, right? Again, it is just a way to signify that you have knowledge of how to implement developmental care.
And we already know how important it is to share that knowledge and to be able to say that you have that designation and you have that knowledge, because knowledge is power, and you'll have the power to make so much change in your unit. William, thank you so much for joining us today and sharing your expertise and passion for developmental care. You made it feel approachable and really meaningful to everybody that works at the bedside. I hope today's episode inspires our listeners to dive deeper, explore NANN's new Neonatal Developmental Care Specialist designation, and continue building NICUs where babies and families can truly thrive. Make sure you never miss an episode of NANNcast by subscribing now. This podcast is made possible by listeners like you. Thanks for your support and letting us into your ears. Have a great day.